Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We're glad that you're here with us, and we hope that you're still paying attention to some of the restrictions relative to COVID. So please do, and let's all stay healthy. Today we have a wonderful opportunity to talk about things that you brought to our attention. And our guest is Dr. Justin Muskovich. He specializes in issues relative to kidney stones, treatment and prevention of incontinence, and prostate health. Welcome, doctor.
Thank you. It's good to be here.
Again, as we were discussing prior to getting on air, these issues really come to us from the viewers, and knowing that you have been so active in your practice in the areas relative to what I just mentioned, and knowing how interested HCA is with your activities and capabilities, I reached out and asked if you would be our guest. So we're glad to have you. Let's start with one of the issues that is always available for commentary, and that's kidney stones. And a lot of people have thoughts that, well, only elderly people have kidney stones, which is untrue. So it's in your hands right now.
Well, that's a very good observation. I think a lot of people, unfortunately, until you get one, you never think about these things. When you do get one, it becomes an emergency pretty quickly. I believe you said you've been a victim yourself, so I think you understand what I'm talking about. I would say that people of all ages get them. They're very rare for children and pediatric patients to get, but to understand why they happen in all age ranges, it really have to take into account factors that cause them. So down here in South Florida, we live in what we call the Stone Belt. So the southeastern United States, sure you know this, is very hot and very humid. And to be honest, the biggest cause, the number one reason that I see that people develop kidney stones is actually from just being dehydrated. Even when we think we're drinking enough water, we normally aren't. We're losing water to sweat. We don't realize it because of the humidity. And it takes about 8 months for a stone from forming a stone to passing it. So we really see two spikes throughout the year. Beginning of the 8 months from the beginning of summer. So around November, down here around November, we get a huge spike. We get a spike a little later in March. Like I say, the number one cause is dehydration. Stones are a big problem when they cause a problem. A lot of people will have them. They'll be silent. You never even know they're there. But the only reason they ever cause a problem is when they start to try to pass. Most people assume that it's a sharp rock scraping up the insides that causes a great deal of pain. But the truth is, it's purely the plumbing. They plug up the pipe, which causes pressure inside the kidney. That pressure in the kidney stretches the kidney, and the pain that you get with a kidney stone is actually an organ pain. So it's really similar to having, a gallbladder attack or pancreatitis, really, when you think about it, because it's just such a deep pain. There's really nothing that makes it better or worse. The stereotypical thing you see people in is the fetal position, rocking back and forth, because nothing makes the pain go away. I said that most stones are caused by dehydration, but there are metabolic reasons that people can have, conditions that are genetic that can cause people to pass stones younger in life. So we do take that into account. And when young people are passing a lot of stones, we can do a complete workup and figure out if it's the way the body's processing all of its waste products that's causing the stone formation.
Isn't it, it's just very quickly, because I want to move on to the other two areas, but it's the intake of certain, I guess you could say, foods, primarily, I guess, certain vegetable and fruit items, correct?
Correct. That can contribute, absolutely. So foods that are rich in oxalates can contribute to stone formation because 85% of all stones are made of a form of calcium oxalate. So when we talk about that, you touched on certain vegetables. So your leafy green vegetables, spinach and kale. And although we tell people to eat their leafy greens to stay healthy, there's unintended consequences. Other oxalate-rich foods are teas, cheeses, dark chocolate actually has a lot of oxalate, certain nuts, almonds. There's a list that, through a simple Google search, you can find for a stone diet, you can avoid those foods. In my mind, the biggest two things that can help prevent stones are A, to make sure we're drinking plenty of water. That's the number one thing. And the way I describe it, especially to my patients in my office, is since the kidneys control our fluid balance, when we're low on water, our kidneys are going to actually pull water out of the urine. So what happens is all those waste products become concentrated. And the way I describe it is if you pour some sugar into a cup and pour a little bit of water over it, the water looks thick and cloudy, but if you fill the glass all the way up, the sugar dissolves completely. So as long as you're pumping out plenty of water into the urine, generally stones don't have a chance to form. The second thing to help prevent stones from forming is citrus. So anything with citric acid, lemons or limes, lemonade, grapefruits, those fruits can really help prevent stones. So the best thing you can do to prevent getting a kidney stone is to drink lots of water and to squeeze a lemon wedge in it every time.
Okay, let's go. Then the other main issue, another two more issues, incontinence. Incontinence comes to us in various questions and thoughts. And I guess, incontinence becomes a social issue because of the embarrassment, I guess, particularly now with this pandemic, everybody's been watching television so much, you see so many ads, but there's so many ads for these garments, I don't want to use brand names, and they talk about them all the time. Dominantly, the ads are focused on women, but there's male incontinence as well. So let's talk about incontinence. What's the reason why we have incontinence?
Well, when I look at incontinence, there's two main patterns. There's urgency incontinence, which is the overactive bladder. And I know there's a lot of commercials on TV for a lot of different medications where, without saying any brand names, you got to go right now. Then there's other pattern of incontinence. And mind you, there are others besides these, but the majority of people in the office suffer from one of these two, which is called stress incontinence. So stress incontinence doesn't affect men in the same way that it affects women. And what it is it's an anatomic, physiologic weakness of the pelvic floor muscles. So when the pressure in the abdomen rises, it pushes pressure on the bladder. And since there's weakness of those pelvic floor tissues, the urine can leave the bladder unimpeded, more or less. That's stress incontinence. We see that a lot from young women who have had multiple children, childbirths, traumatic childbirths. We see it in older women as well. And that's an anatomic cause, and that can be corrected with some simple surgeries depending on the cause of it. When we talk about urgency incontinence, the main difference is really that is more of a physiologic dysfunction. So the bladder muscles, for whatever reason, we don't know why it happens. It happens once again to all ages. You'd be amazed at the number of people under the age of 40 who come into my office with this problem. But the bladder muscles become completely oversensitive, and since they're involuntary muscles, we don't think about them, we don't control them. When they start to squeeze, we can't stop it. So if they squeeze too hard, the urine's going to come out eventually. Now, it does affect women quite a bit more in terms of incontinence than men, and that's only because women have a shorter urethra and a less robust sphincter mechanism than men do. Men have a prostate, which helps control that a little better, but it can be very uncomfortable. And as you said, it's a social disease. I firmly 100% believe that. We treat a wide range of conditions in urology, and a number of them are as I call social disorders. So nobody likes it when their friends notice them rushing to the bathroom every 30 minutes. Nobody wants to risk leaking when they're out in public. It can be a very embarrassing situation. And even when you're wearing pads, it can affect your mind that, is it going to leak through the pad? Is somebody going to notice an odor? And these are things that are very correctable, and they're very, very, very common. We see them every day in our office.
The next issue, really, and I know that you probably have so much involvement with this, because you mentioned before, relative to kidney stones, the issue of prostate issues, but prostatitis, the issues of the inflamed prostate, the intervention of prostate problems relative to sexual activity, things of that nature, are always queries. And let me just link that for a minute. A lot of people worry about their prostate involvement because they don't like the type of examinations. They don't like the thought process of having to do some hospitalization. But I just want to throw this in for a minute because I know of all areas, minimally invasive techniques have worked magnificently relative to prostate issues.
Absolutely. So that prostate, when it comes to the prostate, and I think what we're talking about so much more so here, and not that it's not an issue, is more of the benign growth of the prostate, so the non-cancerous growth. So, obviously, whenever anyone has a problem with their urination, or as they get older, or has prostatitis issues, the number one thing that goes through people's mind is prostate cancer, first and foremost. And to be honest, it's good that people are aware of prostate cancer, but prostate cancer, for the most part, tends to be pretty asymptomatic. And the fact that we have such rigorous screening protocols now rarely progresses to the point where it causes problems. So when people present to the office with, like you said, pain after sexual activity, or prostatitis, or urinary issues, generally we're looking at issues of enlargement of the prostate. Now, the physiology behind it, once again, and I joke about this with every one of my patients, I'm just a glorified plumber, and nobody calls the plumber to come clean out the pipe before it's a problem. But as soon as it's a problem, you're getting into the doctor's office. You're getting the plumber there right away. Same thing for me. But people, don't tend to come in prophylactically, but they present to my office when they've seen a primary care physician, and they may or may not have tried some of the medications, and they're not working very well. So, as we touched, enlargement of the prostate causes a lot of urinary issues. I know we talked about incontinence, and surprisingly, enlargement of the prostate in men can lead to incontinence episodes for two reasons. One would be an inability for the bladder to work properly anymore due to just muscles getting tired from working against the blockage. The other is overactivity of the bladder from the muscles becoming spastic from having to fight that blockage. The good news is that in this day and age, very, very, very treatable, multiple options. Even just the alpha blocker medications are very effective at controlling symptoms of enlarged prostate. I always warn people, and one of the problems of treating prostate enlargement is the medications truly aren't a cure; they're a Band-Aid, is what I say. So they mask some symptoms and prevent some symptoms from happening without fixing the root of the problem. And what I mean by that is Lomax, for example, tamsulosin, one of the most common medications I prescribe. It relaxes the prostate, which helps the bladder work easier, calms the bladder down. So you may not wake up as many times at night. You may have an easier time getting the urine out, but the prostate continues to grow even while you're taking it. So any man who lives long enough is going to experience problems with their prostate. It affects some men when they're 50, some when they're 80. We just never know when it's going to happen. I hate to take that fatalistic attitude, but it was one of the design flaws of the human body, but it's the truth. And so, younger men, I always advise them that, hey, we're going to start you on the medication and someday you're going to probably need something done. And even today, the options are numerous in terms of treatment. So there are multiple simple office-based procedures, and not every urologist performs every one. Not everyone works equally. But I would say that currently there's a couple of great options that are really penetrating the market right now. So there's a steam procedure called the REZUM, REZUM. And what it is oftentimes done in the office, but by injecting a needle into the lobes of the prostate, you can inject steam, and that steam then causes rapid cell death of all the prostate cells and removes the clog. In very similar fashion, there's something called the Urolift, which is a couple of sutures that are placed through the prostate that work like, for lack of a better term, they work like curtain ties, where if the prostate, I'm going to use my hands, grows and closes up, you can put these sutures in to open it up, and it kind of solves the problems there. There's a wide array of simple procedures. There's increasingly difficult procedures. There's some procedures that require hospitalization. It is very rare to need any kind of open or robotic surgery for prostate enlargement. The most common gold standard is the transurethral resection of the prostate, or as I always call it to my patients, the roto-rooter, where you use an electrical loop to cut and shave out the prostate from the inside. And the whole goal of all of these procedures is really just to open the channel and allow the bladder to work easier.
Again, the last procedure that you talk about is what I would, unless you feel otherwise, is a minimally invasive technique. And there are three things that come up all over these many years that we've been doing this show. It always relates to pain, cutting, bleeding, and I guess you could say, the thought that I'm going to be hurt, and not only pain, but I'm not going to be normal. So minimally invasive techniques are very appealing to the people who communicate with us all the time. I mean, everything from stents in cardiology to what you just related to in the prostate. And I guess that there's a lot of non-knowledge out there, and that's why we like to have these shows, because we're trying to give information to the viewers so that they don't have the fear. But to that issue, we've had a lot of commentary over the last couple of years about PSA testing. What's your commentary relative to PSAs?
So one thing that I advise patients, I laugh at this, and I think you'll understand what I mean, is, let's put it this way. As a urologist, having worked, as a private practice urologist for 6 years with 6 years of residency before that, so 12 total years of experience, PSA testing is still a topic that can be confusing to me with all the changes that go through. Now, part of what the confusion is there have been landmark major studies done within the past decade that may or may not have said PSA testing is not effective and doesn't need to be done. My recommendation is always that the American Urologic Association, my governing body, heavily disagreed with that major study that was done. So we do fight that frequently because a simple Google search will normally pull that up. The main thing to me is with PSA testing, with treating prostate cancer, is that I think there was some value to some of those tests, those studies that have been done. And I think the value is, as a community, as a urologic community, we are every day trying to prevent overtreatment of prostate cancer. And that was what those studies were really to do. 20 years ago, if a PSA was high and it led to a prostate biopsy, very low grade prostate cancer, more often than not, that would lead to having a prostate removed. And through time, we've discovered that a very low grade prostate cancer may not be anything that ever will affect a person and may not be something that should be treated. So we've instituted many new protocols that we call active surveillance, where we're more comfortable watching some of these low grade. And please, I have to say that every patient is different, and every patient should have a discussion with their own physicians about these individual scenarios. But knowledge is power. PSA is not a perfect test. I 100% agree. And it has led to, people having multiple biopsies with multiple negative tests. But at the same time, catching prostate cancer early allows you a chance to watch it. It allows you a chance to treat it before it can ever become a problem. And the beauty of what PSA has done is it's really eliminated the number of metastatic prostate cancers that, were seen, as 20, 30 years ago, which would become very, very painful and just a terrible disease to treat and to live with, to be honest.
Well, again, like I said, this I think self-imposed, and I don't want to, I'm not playing doctor, but this self-imposed battle of whether you have PSA on an annual basis versus 2 years versus 5 years is something which comes up relative to the people, because they see different physicians who have been trained at different points of time, the last 10 years, the last 20 years, the last 30 years, the last 40 years, and there's different, I guess you could say, applications of information. It's not knowledge, it's information which creates knowledge. So I thought that it would be a good thing to bring up. The other thing is, you talk about the biopsies. They were very prevalent, I would say, within the previous decade. There are a lot of punch biopsies that were done.
I think you touched on something that I didn't actually mention, which is really some fascinating developments in the past, I'll say in the past 10 years. So MRI protocols for the prostate have become increasingly common. And rather than, 18 biopsies, or there's a saturation biopsy where, for gentlemen, I'll say, 10 years ago, if the PSA was still high and you had a negative biopsy, we might say, well, we should do a saturation biopsy, where you'd go to sleep and get 36 samples taken out. And, that leads to a lot of frustration from a patient's perspective, because, hey, if you do 36 biopsies and nothing comes back, there's still that element of fear of, did you miss something? Or why are you doing this to me? Because, everything's been negative. So MRI protocols have really come into play. And, once again, the more often than not, and this is what can make things confusing for us in urology, is that all of these developments for prostate screening, they're risk assessments. And I think that's an important thing. So there's a lot of genetic tests, and MRI, I'll say that, are risk assessment. But, the MRI, there are certain characteristics that prostate cancer tends to take. So a radiologist can read an MRI and give us a score of 1 to 5, with 5 being very likely, can find any suspicious areas. And with an MRI, there's actually new targeted biopsy techniques as well, where and these take place under an anesthesia, of course, but where you can actually use an ultrasound, which is how we normally do a biopsy, a real-time ultrasound, but superimpose those images from an MRI onto a real-time ultrasound. And it just gives us a much more accurate sampling of the prostate than we ever have had in the past.
Doctor, thank you. We're down to the last minute of this show, but I really thought it was very important to get that information out. I want to thank you very much, Dr. Justin Muskovich. I will tell you this, that we're very pleased. Again, where's your offices?
It's in Port St. Lucie, right by the spring training of the New York Mets.
Okay, so anybody that wants to contact you, we're going to put up a contact number, and you'll be hearing from people in that area and maybe some other areas. But I want to thank you very, very much. I want to thank your corporate reliance, and HCA has really tried to make that venue up in your area a premier venue, and I'm sure that you're very pleased with your affiliation. So thank you very, very much, Doctor. I think that the people who asked these questions wanted it from an expert. So I declared you the expert, okay? So thank you very, very much for being here today. Remember, folks, this is your show, and I want you to take good care of yourself. You heard the doctor talk about seeing your physician and get these checkups. The best way to avoid any problems is to talk to your physicians. Don't stay away. Don't wait until you have a problem that you think is bothering you. Let them see something before it bothers you. Again, this program is called Dateline Health. If you have any questions or comments, there's an email address and a telephone number right here, because we'll get the answers to you. Remember, this program comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.